Okay, so thank you very much. We are not having lunch right now because we have something fairly extraordinary, and that is a member of Congress who is taking time out of his day to speak to us briefly. I want to introduce our Luncheon keynote speaker, Senator Ron Wyden. He is a ranking member of the Senate Finance Committee. He was first elected to Congress in 1980 to represent Oregon's 3rd District. In 96, he was elected to the U.S. Senate. Prior to his service in Congress, he co-founded the Oregon chapter of the Gray Panthers. This document says that's an advocacy group for the elderly, in case you didn't know. He also served as the director of the Oregon Legal Services for the Elderly. He has done an awful lot of good and interesting stuff around healthcare, and I have been involved in healthcare in Washington for about 150 years, and this senator is the most knowledgeable guy on Medicare as an elected official I have ever met. So, Senator, thank you very much for joining us.
Thank you very much, and it would be cruel and unusual punishment to filibuster friends, and also there isn't the time because I've got to get back on the floor. We're going to be kicking off the tax debate at 2 o'clock this afternoon, and thank you for that unquestionably inflationary introduction. My wife and I are older parents. My wife owns the Strand bookstore in New York City, and our 4-year-old actually turned 5 this morning, and she recently said, "Dada, what about these Pink Panthers?" And I'm going to have to educate my kids in the years ahead about my roots. I'm here primarily because Len and Mark Gantz, old friends, and I think you're doing especially important work right now when we are sort of at one of those kind of inflection moments in terms of the continuum of care. And it looks to me, as if this was a stool, you'd be talking about improving the way chronic illness is managed. Second, you would address long-term care, and then you would come up with common sense and compassionate approaches for end-of-life care that especially empower patients. And these are the 3 areas that really drive much of Medicare and Medicaid spending. And with 10,000 people turning 65 every day for years to come, this is going to be what drives American healthcare. Now, I want to kind of do a little poll because I think it will illustrate a little bit of the challenge we have in American healthcare. How many of you were aware that the Senate passed unanimously, 100 senators here recently in the last couple of months, a major bill to transform Medicare with a focus on chronic illness? All right, maybe a third. How many of you never heard of such a thing? How many of you heard maybe a couple sentences about it? Okay, a lot of people in the third group. And that's not to give anybody a hard time. 10 years ago, the bill that passed the Senate would have been on the front pages of every newspaper in the United States because it is truly transformative health policy. And today, because nobody is fighting, slugging each other, accusing people of various and sundry, misdeeds, it won't get on television, period. End of discussion. This has gotten a few lines in various journals, and if it wasn't for Kaiser Health News, I'm not sure anybody would have actually reported what happened. But here's why it is such a big deal. When I was director of the Gray Panthers, and this was early days, Medicare had been in place for a decade or thereabouts, Medicare had these 2 parts. There was Part A, that was a hospital, broke your ankle, had to go to the hospital, get it surgically fixed, Part A of Medicare, the end. And then there was Part B of Medicare. That was like if you had a really bad case of the flu. I mean, like a whopper. You went to see your doctor. That was Medicare Part B. That's pretty much Medicare for some time. That does not resemble Medicare today. Today, Medicare is about chronic illness. It's about cancer, it's about diabetes, it's about heart disease, it's about strokes, and it's about people who have one or more of these conditions, as you pros in the field would call them, comorbidities. Always sounds kind of spooky to be talking about morbidities, but I guess that is the technical lingo for it. That's 80% of the Medicare spend and going up. So the reality is, if Medicare today was just about broken ankles, bad case of the flu, you'd never see another TV commercial with a politician talking about Medicare or attacking somebody, or they don't care about Medicare or something like that. And the reality is, both political parties have missed what Medicare has become. Both of them. I want to underline both. During the during the debate over the Affordable Care Act, chronic disease barely got a mention. Barely got a mention. And actually, the only mention it got was in connection with the Independence at Home program that I wrote with then Congressman Markey. He was in the House and the Senate, and old friends, and we were the lead Democrats. We got Republicans to be for it. And that, of course, has brought Medicare into the process of caring for people at home. But nobody talked about chronic illness. Nobody talked about what Medicare had become. And the reason that I found it is, some of you may know that in 2011, I wrote a paper about Medicare reform with Paul Ryan. And man, you would have thought Western civilization had ended. Oh my God, the director of the Gray Panthers is writing a paper with Paul Ryan. Oh my God, the Western world as we know it is going to end. Well, what I was talking about then, and I come to talk to you about it today, is updating the Medicare guarantee. That's what our chronic illness efforts are all about, is updating the guarantee. Medicare is not a voucher. It's not a slip of paper. It's not something that you just take out the door and hope it works out for you and the like, but it's a guarantee. And what we have done is update the guarantee. We want people to have access to more non-physician providers. We want patients to have access to more telemedicine services. My dream for this chronic care initiative is I want everybody with 2 or more chronic conditions to be able to have somebody who rides point for them in terms of coordinating their care and helping them actually navigate this Byzantine system. So we passed the bill. It's just the beginning of the story. It is not the end of the story. The House is working on it now. I think it is always hard to divine the machinations of the House of Representatives, but I think we're going to get it passed in some shape or form. But this is the beginning, folks, of transforming the Medicare program. Make no mistake about it. The program that used to be about treating broken ankles and bad cases of the flu is headed for a future built around more effective, more compassionate treatment of chronic illness. And by the way, this is going to start jump-starting some prevention efforts for the under 65 population, because people are going to say to themselves, gee, maybe if we had a little bit more prevention for the under 65 population, you wouldn't have the same challenge with respect to chronic illness in the Medicare eligibility period. Then we move to long-term care, and one of the reasons I'm racing back to the Senate is one of the big fights in the debate about the Affordable Care Act is those on the far right would essentially like to gut the Medicaid program. And as you know, Medicaid pays for much of the long-term care in our country. And what we ought to be doing is building on that rather than going backward. And you're going to hear a lot about the individual mandate and all this kind of stuff. That's not what we're talking about here. We're talking about repealing the law and letting states go back to the days when insurance companies could beat the stuffing out of somebody who had a pre-existing condition. You're going to go back to the days when health care was for the healthy and wealthy. So I went to school on a basketball scholarship, dreaming of playing in the NBA. Ridiculous idea because I was too small, and I made up for it by being really slow. But I'm going back to put up the toughest fight I possibly can for the Affordable Care Act this afternoon and tomorrow and what is likely to be Friday. And I'd really encourage all of you who have contacts with friends and others close to senators, particularly Republican senators, tell them, and it comes from your heart, that you don't want to turn back the clock. That's what this is. This is not a technical issue and that, well, it's just the individual mandate. It's, as you know, right at the center of how this act operates. And by the way, this act wasn't even my first choice. I had something called the Healthy Americans Act with 8 Democrats and 8 Republicans. That was my first choice. Everybody who wasn't on Medicare in the military would have private sector choices like their member of Congress. And the budget office gave us a score that it was revenue neutral. So that was my first choice. We got some provisions, particularly the loophole-free protection against discriminating against people with pre-existing conditions into the Affordable Care Act. But we ought to be building on this, not turning it back. And apropos of this meeting, if you repeal the Affordable Care Act, you repeal the purchase requirement, which is front and center to the ability to have an efficient, responsibly financed, program. We're heading back, to the old days. We're certainly unraveling the Medicaid expansion, and we're going to unravel, in my view, a serious part of the nursing home benefit for long-term care. And as you know, Medicare doesn't provide long-term care services in the custodial kind of context. So we're looking if we can manage to somehow not just play defense all the time, but look at play some offense, trying to figure out some fresh approaches to financing a bigger role for long-term care under Medicare. But today, we're involved in a rearguard action. Now, I'm going to close with a quick comment about end-of-life care. Actually, 2 quick comments, end-of-life care and pharmaceutical benefits. I thought that after I blocked the Terry Schiavo bill on the floor of the United States Senate, and I was a young United States Senator, and Bill Frist, as you know, said he went into his office and he read the x-rays and there was life, and so we were going to vote on a bill to make the decision as United States Senators, who of course were superbly qualified to make these decisions. On the floor of the Senate, they asked for consent to bring the bill out. I objected. And nobody much knew who I was, and kind of the way the Senate works in these kinds of moments, people are in their seats, and many were, the whole room turned to look at me, sort of like, who's this guy? Is he an actual senator? We don't know him. And I said that. I said, I'm new to the Senate. Don't pretend to know everything, but let's make sure everybody understands what this is about and why I've objected. If we pass this bill and have the United States Senate actually intervene and decide when and under what circumstances here on the floor of the Senate, people are given life-sustaining possibilities, we are going to change the United States Senate for all time. We will, if the first bill passes, become a medical court of appeals. And our corridors will be filled with families and friends and petitioners of all sorts who ask us to get into this. And I don't know about you all, and probably hardly anybody knows anything about me, But I think that's a big mistake. I just got here. It's supposed to be a really wonderful place. Lots of terrific things. It's a big mistake. And I objected, and we basically killed the bill. As you know, we went off and turned it into what the Senate does, these kinds of things, made it a nothing burger, and that was it. So I thought we were really on our way. And then along came Sarah Palin. And Sarah Palin told what William Peter Wyden, my 10-year-old son, would call a really big whopper. Sarah Palin said, problem with the ACA is there are all these death panels. As you know, there were no death panels. But she basically put us back in another tailspin. So there we have been for some years. But one of the things that we did in the ACA, and I call it the Send Sarah Palin a Message bill, is we got a change in hospice policy that said for the first time in America, somebody would be eligible for curative care without giving up the hospice benefit, so that nobody could say you were taking away opportunities for life. Now, as you all know, the vast majority of patients in this kind of situation do not believe they're going to be cured and then go off and play forward for the Portland Trailblazers. Not on the level. But everybody wants to have hope. So we got this passed. It is now part of the expanded ACA experiments going on in various places on the level, at the local level. And what I think it's showing is that we're going to start once again expanding choices where the patient and family is empowered to deal with these kinds of issues. So Mark Gantz and others are doing some very good work, and I appreciate particularly their philosophy of saying that they want this to the greatest extent possible to be driven by patients and families. That's what Mark has really kind of cemented in this conversation in our part of the world. And that, I think, ought to be unifying politically as well. Because if you go from Schiavo to Palin to today, the question is, how do you find some common ground? We did it around hospice and curative care, and we're going to need to do more. Last point I'm going to make is on cost containment, and then I'm going to have to get out the door, is we're spending enough money today on healthcare. We're going to come in this year around $3.3 trillion. There's like 325 million of us. Somebody wants to use their device and do the math. I think it still comes to like $35,000 for a family of four, certainly upwards of $30,000. If you just wanted to give them $30,000 here, go get yourself a nice policy. We're spending enough. We're not spending it in the right places. And a big part of what we have to do is find fresh strategies for cost containment. And I'm just going to close by way of saying that what I have put at the center of my focus for cost containment is trying to protect those who provide real value to patients and families that really pay off in measures that we can really examine and make sure actually deliver. And then there are a whole lot of middlemen in that $3.3 trillion who are taking a lot of money out of the system with virtually no transparency and no accountability. And the perfect example to me is the pharmaceutical benefit managers, the PBMs. The PBMs may have made sense 15 years ago because they had data and they had expertise, and they would tell big buyers, insurers, businesses, labor unions, states. We're going to get you a good deal. Well, today, there are a whole bunch of people who have data and expertise, and there's virtually no transparency surrounding these PBMs. We don't know what they're putting in their pocket and what they're putting in the consumer's pocket. So I would just say that as part of the strategy that you are evolving into, as you look at the various pieces of this equation, I tried to touch on the ones Mark said you were most interested in, we're going to have more cost containment, and the focus ought to be on the middlemen. So I wish I could stay and have a conversation with you, but I got to be on the floor of the Senate here managing this bill in about an hour. But big thanks for the good work you're doing, and for Len and Mark, I look forward to continuing it, okay?